Katie, and thank you everybody for coming. The longer I do this, the more I don't know, people keep saying, are you going to retire? And I keep saying no, because we're learning so much and it's so much more fun these days. Not that it's fun to have migraine, but we have so many things coming to our patients, and it's just exciting, to have been around to do this, to watch my father do it before me. Very, very exciting, and a wonderful place to be. And, I think there was recently an article published about the potential for vaccines for migraine. And while we're not there today, what a long way we've come. And it just seems like things are really progressing much more rapidly than they did in the past. So I think what I want, and I didn't prepare slides tonight because I think, I just didn't. And we can talk about stuff. I think if you put up all kinds of different mechanisms of action, when we don't know if even some of those medicines will work or come to fruition, it's easier for me to think about clinically what's going on. And so I think the first thing I wanted to address is that as patients and as an advocate for patients, and having been a migraine sufferer myself, and I have 4 kids who have migraine, so I know the deal and how much impact this has. I think as a clinician, one of the things that really affected me in this last month or two was looking at not just migraine attacks, but that interictal burden that we all suffer with. So it's not just the headache itself, but all the other pieces that come with it. And being able to express that as a patient when you go to see somebody for your migraines is going to be really important, because I think sometimes we just look at the number of headaches and not necessarily the impact. And as you all know, and I know from doing what I do, that migraine seeps into every part of our lives. And so importantly, we want to, when we come in and we bring our headache diaries, or when we come in and we are doing a new patient consultation, I think it's really helpful to talk about not just what your attacks are, but what happens in between your attacks, the things you don't do because you might not be well enough, the jobs you don't take, the events you don't plan. And I think it is helpful for patients because it allows us to understand the depth to which you have impact from this disease. And I find it really important that we're not just going to look at pain, but we're also going to look at all the other pieces that are important, and looking further into that. And I think that that's really, really important for patients in general. So I just want to hit some of the newer things that we're looking at, and I'm kind of going to go from what we know today to what's cooking in the pipeline. So I think one of the big things that has happened in the last about 9 to 10 months is that there's been sort of a loosening of the grip of the commercial insurers, because we now have data that shows that combining therapies are really, really important. So we've been focused on CGRP for several years now, but there are patients who need a combination of CGRP with, for example, onabotulinum, and many commercial insurers have limited that access. And I'm happy to say that over the last 6 to 8 months, most of the commercial insurers will now let us do both, which is a really, really important thing, and came from advocacy, really, getting these things approved. So there's power in all of us coming together to make those statements. We've also learned, for those of you that are CGRP responders, that there is now good data that shows that you can be on one formulation and add another formulation on top of it. So there's always been this concern about safety, how much CGRP is too much to block. And I think the way I look at it, and I'm kind of a simple person, so I'm going to tell you what works for me, is a neurotransmitter. When we talk about dopamine or serotonin or one of those other neurotransmitters, when a neurotransmitter is released, it's like a teaspoonful. And when we think about CGRP, it's like a bucket that gets released. So it is indeed very, very hard to block at all. And so I think that lends itself to the safety that we're seeing with a number of these agents, which is really, really important. And so there've been a number of papers published about combining a monoclonal antibody with an oral CGRP, and perhaps on a botulinum on top of it. And the way we always used to look at this stuff was, well, are we looking at different mechanisms? And from those of us who, do this every day, I think it's very, very clear that for many of our patients, CGRP isn't the only thing there. It's helpful, but we need other agents with it to make sure that we keep patients in remission for long periods of time between attacks. So I'm going to start with the first device change that's going to happen, and that is that the people at Theranica, which makes Nerivio, have now applied for a preventative status for their device. They have fairly good literature associated with it, and so what they're looking at is a preventive indication. The biggest issue I have with devices is, well, there's two issues I really have. Number one, they oftentimes come to market without a ton of data because the FDA lets devices through much more easily than they do medications. So sometimes it's a paucity or a lack of enough information. And then the second piece is that most insurers won't cover these devices. So it's difficult for patients who need to continue to buy refills to make the device work, to get it to work. But it is very exciting. And we've used the Nerivio a lot on our inpatient patients. And it's been a very successful tool for them. So getting a preventive indication would be great. And hopefully the FDA will recognize it enough to push the commercial insurers to get it covered for patients. The other device that's coming to market, but sort of launching slowly, is Relivion. And so Relivion is a little bit different device. For those of you who don't know what Nerivio is, it looks like a little blood pressure cuff, not cumbersome, and you can fit it on your arm. And what it does is it sends signals to block the release of the ascending pain fibers. So it's not really a TENS unit like Cephaly is. It actually works on specific nerves to block pain transmission. And we've had a lot of success with that. And it's particularly good for patients to treat an acute attack, but it's exciting to know it may be available for prevention soon as well, and hopefully with some coverage. The other device, Relivion, and this is the other thing that often happens with devices, unfortunately, is that they're startup companies and they run out of money. So Relivion was supposed to launch probably about 1.5 years ago, and it's a little bit different device. It sort of looks like an angel halo. It's very lightweight, and it has 2 probes up here that go to your superior orbital areas, and then it has 4 probes for your occipital nerves in the back. It again has pretty good data, and hopefully it will come to market in the next little while. And so that's some exciting stuff just from a device point of view. I find devices really, really useful for patients during pregnancy because they're safe. And we're always looking for safety in these things, which leads me to my next comment, and that is on Ubrogepant. Or Ubrelvy, which now we know is safe in breastfeeding. So just a little something to add to our armamentarium for those of us who are treating a lot of patients who have babies and want to know, if they get a migraine, what can they take safely? And again, the concentration is really, really low, so very safe. And now, last but not least, I'll get to some of the newer medications. So there will be a nasal CGRP blocker that will probably come to market in late spring, early. They used to say first quarter. So the FDA has a fiduciary date. I have to learn this whole new language, but it's when the drug is due. It's like a baby, but it's when. So when we submit something to the FDA to get it approved, they have 1 year to think about it and look at the data and decide. And inevitably, they never come back at 8 months with a migraine product. I'm sure with chemotherapy, they probably come back a little quicker. But the fiduciary date, or the due date on Zavegepant, which is a CGRP blocker, which is a nasal administration, should be towards the end of the first quarter next year. The advantage of that, I think, for a lot of patients is that one of the concerns or one of the things we struggle with some of the CGRP GPANs is, although they say they work as quick as triptans, I think some patients have to really catch it for them to work as fast. And so having a nasal spray, and the data looks really, really good with this, should be helpful for people. And that's very, very exciting to have another mechanism. However, I always keep it with like a deep breath, because as much as I love nasal sprays, sometimes my patients don't like them at all. So, but I come from the school where my dad used to give people suppositories, and he would tell me, Merle, just use a suppository. And I don't know how he got people to do it, but I have never been successful getting anyone to use a suppository in my whole life of doing this. So, so that's good. There is also a product, another DHE product that will be released in a powder form. Again, an inhaled device, but instead it's a powder. It's by a company called Satsuma, and that will probably come to market sometime next year as well. A little update on atogepant or Qulipta. They are going for a chronic migraine indication. They don't have it yet, but they have applied for that. And so I'm just going to talk about a few other things. One of the other targets that we've found is something called PACAP, which is another neuropeptide. PACAP comes in multiple forms, like A, B, C, D, 1, 2, 3, 4, and then all the little letters after it. We haven't quite decided which form of it we like to prevent migraine, and so it's actively being studied, but so far has not kind of come to fruition at this point. There is, and I think this is super important, there's a drug called Alod-2. It's manufactured by Allodynamic Therapies. So it's really, really interesting to me as someone who treats a lot of chronic migraine patients, and that this may treat allodynia. So, you know, for all of us who struggle with, you know, sore heads, an inability to touch your hair or wear your glasses because you've developed central sensitization, there's actually a product that's being developed that's targeting central sensitization. And it's in phase 2 and phase 3. So when they do phase 1, what they're looking at is mostly animal studies, and is it safe? In phase 2, they'll take healthy subjects, and then in phase 3, they try to find the dose and what is the and whether or not it actually works. So this phase 3 anti-allodenic medication works on cyclooxygenase. And so for those of us with biochemistry interest or not, it's a lot of the places where the non-steroidals will work, but not have an effect on the gut in terms of problems associated with it. There are also some opioid receptor agonists, which without altering your ability to function may be a thing in the future, and those are in phase 2 studies. There's also a phase 2 medication, which is an acetylcholine inhibitor. It is a drug that works like anabotulinum. So lots and lots of things in the pipeline. I think the exciting thing as a clinician is that for a number of years, up until really the first monoclonal antibody came out about 5.5 years ago, we'd never had anything really made for migraine before. Even Pat Humphreys, who synthesized sumatriptan, you know, the guy that made sumatriptan and developed it, it was actually supposed to be a diabetic drug when it was developed, and accidentally he created this thing that he won a prize for. So, you know, I think the important thing today is that we're able to look at these targets and actually utilize our science to combine things and put things together that we couldn't in the past. And so I think that that's really, really important. And whenever I talk about what's in the pipeline, and I think we have so many gifts today, I'm reminded every day, like I saw about 20 people today in my office, and I'm reminded every day when I see people that we still have a long way to go, because invariably every day from a patient or 2 or 3 or 5, is there anything new, Dr. Diamond? So we still have a long way to go to reach everybody and to be able to help everybody. I love the fact that there's so much open data sharing at this point, and that we're looking at not just medications, but also other options. I think a couple times ago, I talked about that ally lamp that's been available that Rami Burstein developed. I have to tell you that I think that's made such a big difference for my patients who have so much computer time to do. It's really effective. It helps them to participate more with their family, be able to be in the TV room with the lamp on and with other people, as long as it's not too loud. I'm not suggesting like maybe a really action-packed movie, but something where you can participate with family. And I think all those things are really good. And it's through researchers like Rami, who's such a humble guy, that we're actually able to look at these targets and know what we're treating. Anyway, I think I've talked long enough, and I'm happy to open the floor to any questions.
Thanks so much. That was great information. I totally agree with you about the ally lamp. So our support groups are at the end of the day. They're usually at 6 o'clock, 7 o'clock at night Eastern time. So, you know, we have people in California obviously on at 4,
Right.
but so many people come on to our support groups with all of their lights off and their ally lamp on.
Right.
And it makes such a difference because they're able to attend. And the ally lamp is just very soothing, and they're able to be on the support group because of it. So
Right.
total agreement with that.
Yeah.
And you know, and everybody, because the holidays are coming up, there might be some discounts out there for the ally lamp too. That
Right.
of course is not covered by insurance too, but we in our support groups and things, will always, if anybody has any discounts, we always put them out there for the glasses, for the ally lamps, for anything, you know, we put them out there to our support group. So if anyone
Wonderful thing about,
support
yeah, I think one of the wonderful things about the LA lamp is it's a one-time cost, and you don't have to keep buying.
True. Yep.
And it's
Right.
portable, so you can take it with you.
It really is. Yep. And it's not on batteries either.
Right.
So that's another awesome thing, is you just charge it like you charge your phone and stuff. So that's such an awesome thing too. A lot of things these days are now not battery, they're, you know, just chargeable. And so speaking of that too, a lot of people come on our support group at the end of the day with migraine glasses on. What's your thought on those? That's one-time cost too.
Yeah, so that's a one-time cost too. I think the problem is, at least in the, you know, I sort of quiz people because I'm not sure, right?
Mhm.
It's been hard for people to say this one is better than that one, so it's hard for me to recommend, because I have some patients who do better with one type of block than another one. I do think the red ones work well for people, but it's variable, right?
Yeah. Yep, absolutely. You're right. We have all different glasses on in our groups. So
Right. And so that could
And-
be a bigger cost, right? Because you have to find the one that works for you.
Right. Yes, very true. So so those are out there too. I think a lot of them, from research that's been done in our support groups, and don't quote me on this, but I think you can try them and return them, and maybe some of you know that, and you guys could put that in the chat. But I think they're returnable if you don't like them, but don't quote me on that because I don't have any myself, but maybe someone can throw that in the chat, the glasses. So let's get to some questions too. Diane wants to know, any ideas on how we use Nerivio as a preventative?
Yeah, so the general direction with Nerivio is that when you're using it for an acute migraine, you're supposed to keep it on for 45 minutes. And I do think that that's been sort of a challenge for people. You know, do you have 45 minutes to do it? I think if you're Zooming and you can have it on, that's great. You know, if you're in that sort of situation. So it will be a 45-minute treatment during the day. They are looking at opening up something where you could do something twice a day. So the original study was with once a day, but they may look at other options as well.
Great. Okay, thank you. You know what? How about do you want to make this a little more less informal? How about I call on you? Would you guys like to ask Dr. Diamond your own question?
Please.
Do you want to do that?
I don't bite. I'm
yeah.
super easy peasy.
Yeah, Laura Loretta, do you want to ask her your question?
Sure. Hi, thank you for speaking to us today. Excuse me. I've had a lot of luck with cephaly, and my doctor said that he wanted me to increase how much I use it. So now I'm using it 5 or 6 times a day, and that's been beneficial, but I'm still having a lot of migraine.
In between.
Yeah, in between. And I just started the IV treatment, and that hasn't really helped much. So they're talking about implanting some kind of thing in my forehead. And I was just wondering if you've had any experience with that, or if it's any more beneficial or anything.
Yeah. So there are all kinds of, so originally when we looked at that stuff, it was looked at in patients who were Botox responders. And when they looked at it, those were the patients. So there's 2 different things they do. They can do a stimulator in there, or some people just went in there and they kind of cleaned out the area so there wasn't so much scar tissue around the nerves. I think probably the stimulator overall has better data. The biggest issue with stimulators, whether they're in your forehead or your neck, is the anchor. So sometimes the leads move and then you lose efficacy because they're not quite in the right place. So when they first put it in, they have you do a trial and see how you do to make sure you'll be a responder, and then they'll implant the device usually. I have had patients do well with it. And if you're a good cephaly responder, that might be a good option for you. Unfortunately, and I have to share this with you, there isn't a lot of long-term data, and it's one of my criticisms. I need for them to show us, it's good at 3 months. What does it look like at a year? And what do you guys do if a lead moves? Is the patient responsible for that? Is it covered by insurance? How do we get it taken care of so that you get access? You know what I mean? And so those are my biggest concerns with it. It's not a big procedure. It's not terribly dangerous. You want to go to somebody who's done a lot of them if you decide to do it.
Yeah, I was curious how if it was a year later that you go in for a little tweak and make sure everything is set.
Yeah, it depends. And again, there's a lot of variability, but it depends what your response is.
Okay, thank you.
Yeah,
great. Thank you. Yeah, thank you so much. Okay, Natalie has her hand up. Natalie, would you like to ask your question?
Yes, Dr. Diamond, could you tell me, I tried all CGRP medication, including Vyepti. I am now on infusion. Is there any medication coming up that are not CGRP class?
Yeah, so there are, that's certainly the hot place today, but again, we're looking at PACAP. We're also looking at these central sensitization modulators. There's tons of stuff, and I think the good news is that there are a lot of people doing research. We're slowly building, we're not only just growing headache doctors, which is critical, but we're also drawing many more people to research. And so there are other things in development. And, it's just a question. Everything got a little bit slow with COVID, obviously, because it was hard to get patients in for clinical trials. And so everything just kind of slowed down, but there are other options. And with the CGRPs, if you're one of the things I've learned as a clinician, for patients who are chronic, and many of my patients have headaches 30 out of 30 days, they have a lot of difficulty with prevention. It's good to stick with the therapy as long as you're not having a side effect. And that is one of the nice things about the CGRPs. If you're not having a bunch of side effects and you're tolerating it okay, really give yourself a good 6 months if you're a kind of a 24/7 person. The early changes may be slow and little, but they are there and they can grow over time. This is the first group of preventive medicines where we see actually that they keep getting better and better over time. I think they can modify the disease.
Yes, I am going to try the second injection. And actually, I had a lot of side effects from Vyepti, but I would try it anyway. But since I tried every injection, CGRP, including oral, non-injection, and nothing worked for me, maybe, and I have a hemiplegic migraine. So
Right.
maybe it's not my thing, maybe some other classes that not blocking CGRP receptors particular, but maybe some other receptors.
Well, and what I was
So in near future, like next day, because I'm like coming out of options, I have this for 14 years, this migraine, and it started after my stroke, hemiplegic stroke. So in near future, is there anything coming except devices?
Yeah, so this pay cap may be a big thing for patients. There are numerous things in the pipeline right now. And it sounds like you don't, so Peter Goadsby, who's sort of one of the grandfathers of CGRP.
I know him, I know.
Right, would say your headache doesn't have a strong CGRP mechanism. And so we have to look at these other neuropeptides that we've discovered and where we're developing clinical trials for those kinds of drugs.
Awesome. That's great. Thank you. Yeah, that's good. That's
Thank
good
you.
information.
Yeah.
Yeah. Okay, I'm going to jump in here and ask a few here myself too. Do inhaled meds, nasal spray, or eye drops have less systematic side effects? Oh, you're on mute.
My dog was emptying her dog bowl. It was noisy. I apologize. So that's a really good question. What I would say is that injectable is going to have the most side effects as an acute medicine. Nasal sprays, if they're tolerated, are really easy. They're just, in general, patients don't love them as much as we love them. I think as clinicians, we like them because we get to bypass your gut, which may or may not be working, but they're just not as popular. People don't like putting stuff in their nose. And so what I would say is most nasal sprays will have less side effect than an injectable and are pretty tolerable, fairly close to a pill, right? And I think the important thing that I always have to remember taking care of patients is what percentage of the time can you count on your oral medicine to work if you have a lot of nausea? So a lot of times, even though we find oral agents easier and obviously less cumbersome, and if you get less than a 50 or 55% efficacy and you have a lot of nausea, it's really important to talk about a different route.
Right. And speaking of that, does a nasal work faster?
It does, yeah. So,
okay.
So it's highly vascularized. And in fact, I can speak about this with Trudessa. So Trudessa was the DHE nasal spray that came out, I don't know, it's about a year now, maybe a year and a half. And so it's still DHE nasal spray, but the device they invented sends the spray superior, so to the bridge of your nose. So the first thing that's important is that you're going to feel pressure at the bridge of your nose. Guess what sits under there? Your sphenopalatine ganglia. So and you got a ton of blood vessels up there. So it is absorbed much more quickly. I think with traditional nasal sprays, depending on how much pathology you have on your nose, you know, like are you chronic inflammation or infection? Sometimes it's more challenging with nasal sprays if you have a lot of sinus disease. I hope
Gotcha.
that answers the question.
Yeah, great. Okay. Let's see. Does Cephaly work with chronic migraine? I was born with ocular amelism and get migraines on daily.
And the question is, does
Cephaly work with chronic migraine?
it can, I mean, I certainly have patients who respond to it. I think, I actually think Nerevio is a better device in general, but again, the beautiful thing about migraine is pick the thing that works the best for you. You know, my opinion does not matter if your device is working for you, right?
Agree. Yeah. I mean, I have a Cephaly, and if I can catch it when it's, I mean, I'm
Right.
chronic, so I always have one. If I can catch it
Right.
right before it goes up,
Right,
it works. If I don't, it doesn't work.
right. And
Right.
so, right, and again, it has a different mechanism than say Nerivio or the Relivion or Gamma Core.
Right.
Yeah, so mechanistically, it's a little different, but if it works, it's great. I mean, it's wonderful, it's
Yeah.
easy, you know,
And I'm not taking another medication.
right. And I think
Yeah.
that's really important. I saw a young lady from South Carolina last week, and they really were not interested in medication, and she had post-traumatic headache, and we just designed a different treatment protocol for her. You know, they were not, between her and her mom, that was not, medicine was not happening. So
Yeah.
we did
So you
other
went-
things, but you know what, it worked. And you know, I try not to have an opinion about that. I try to follow what belief system you have, you know, because it doesn't help for me to like say you have to do this.
I love that. I love that. That's great. Okay, so Dina said, I have intractable migraine and fibromyalgia. She finds that her head and body pain increase and decrease together at the same time. If she treats the fibromyalgia, will that help with migraine? And why do both diagnoses seem connected?
Yeah, so that's a great little segue here. So migraine has a number of comorbidities. And I think fibromyalgia is one of them, even though we still have some people, clinicians, not really liking that diagnosis. And I think it was Richard Lipton. So Richard Lipton, you guys may have heard of, you guys are all pretty well educated, but he is kind of our big epidemiologist. So he crunches population numbers, kind of a dork that way, but he's brilliant. And he presented a study about 3 years ago looking at if you have more than one pain syndrome, what happens? Like, you know, do they feed off each other? And the truth is, if one is poorly managed, the other is often poorly managed. And that's not a blame or shame thing on patients. It's a fact that when your fibro is flaring, your migraine will often flare when your migraine is flaring. And it has to do probably with depletion of endorphins just from the chronic pain that's going on for patients. And so it's really important to address both, right? Same thing, little different story. I have really bad chronic migraine and I have gastroparesis, right? So first of all, we have to think outside the box. If your stomach's not working, how am I going to get medicine into you? That's number one. And number two, as one gets better, the other does. And so somebody will say, well, did I not have gastroparesis? And I'll say, no, you have both. But if you don't have your migraine throwing in your extra nausea, right, and slowing stuff down, then of course you're going to absorb stuff better and it's going to work better for you. So these are areas that are really complicated that we're just sort of learning about, like the whole dysautonomia or POTS with EDS and mast cell stuff. It's pretty complicated, but you know what? We've been seeing you guys for years, and this is stuff that's been there. We just haven't been able to identify it till recently.
Yeah, I agree. I've heard a lot about that too. So I hope that helps answer your question a little bit, Dina. So we have heard, and we actually did something about the gut brain. Your gut is your second brain, right?
Yes.
What are the effects of blocking CGRP in the gut? Why do they cause constipation?
Yeah.
And some of us get constipation from them, some.
So it's interesting. I think you can separate it into two groups, your ligand binders, which are Emgality, Jovi, and Vyepti.
Oh, Vyepti, yep.
Yeah, don't cause as much constipation as your receptor blockers, which are your Nurtec, Ubrelvy, and atogepant. Okay, so Qulipta. So there's something about receptor blockade that simply has more constipation associated with it. And I would tell you from my clinical view, I think Qulipta has a little more constipation than Ajovy. That's just my clinical viewpoint. They're all manageable if the drugs are working for you. And in a few patients, obviously you have to change medicine. You can still see constipation with the other guys. It's just not usually as severe. You have CGRP receptors every place. So you have it in your skin follicles, you have it in your gut, you have it in your heart, you have it in your lungs. And so there, there are some patients who are uber sensitive that will certainly have significant constipation. And we have to watch for that, and make sure patients have good tools for that.
Yeah, because that can be killer.
Oh gosh, it's terrible.
Awesome. Yeah. Okay, great to know. And I like your views. Okay. So vestibular migraine. I have been hearing more and more about vestibular migraine. One of my dear friends has been having more vestibular issues as the days and weeks go on, and my heart breaks for her. And so are there any new treatments in the pipeline for vestibular migraine that you know of?
Not specifically, but I will tell you that there are, and it's because we're a little bit behind, and I'm not going to put myself in that crowd, but the people who write the guidelines, so the classification of migraine, up until a few years ago, this last sort of go through where they add things and subtract things and change names and fix it, is the first time we've actually had vestibular migraine listed as a diagnosis, which of course is problematic, right? Because it's very, very common. So dizzy is a part of migraine over 60% of that time. That doesn't mean you have vestibular migraine, right? That's a separate entity that's obviously much more impactful. And I think we have to pay attention to it. I think it's important to separate vestibular symptoms from orthostatic symptoms or blood pressure issues, lightheadedness, like POTS, from vestibular migraine. There aren't specific drugs, but I can tell you that with good vestibular physical therapy and a monoclonal that's working for you, that's the best outcomes I've seen. But you got to do the deal. You got to do and patients probably want to shoot me, but I tell them you have to do the vestibular PT. It may take you a long time to get up to, something you can tolerate, because it is difficult when you're really in the midst of it. But if you continue to do it and you practice it and just sort of add it up over time, it can be really, really helpful for people.
Okay, wonderful. Thank you for that. Let's see, Robin, if you don't respond to Nurtec acutely, can you respond to it preventatively?
Yes, that's an easy one. Yes, you can. And vice versa. Some people don't respond to it preventatively and do great with it as an acute drug. My word of the only thing I tell you about both Ubrelvy and Nurtec is take them as early as you can, and you don't have to worry about medication overuse. So I have this whole speech I've been doing for 30 years about medication overuse, and now I got to reteach people, don't worry about it with these drugs because you're going to be fine. You can use them as often as you like. Really, Merle? You always told me not to do that.
Yeah, that's excellent. And I always tell everybody, same thing, take it as early as you can, as soon as you know. Make sure you have a spare dose of medication in your car, in your pocketbook, because you need to get it as early. So if it's at home and you're out of luck, right?
Right.
So you need to have them where you can get them.
Yes,
So have a little baggie with one in your car, have a little baggie with one in your pocketbook, or whatever you want to put it in, but you should have one where you can grab it. Because I say that, but then I was talking to Shirley Kessel and I said something about my migraine and she's like, why didn't you have one in your car, Katie? And I was like, because I took it and because I didn't refill it.
yeah.
So, yeah, yep, there I was like, I didn't do what I tell other people to do. So, are there any other neuromodulation devices that might be coming out?
Yeah, there is actually. I just signed a non-disclosure agreement to meet with somebody at the American Headache Society. So I can't tell you what it is. but-
Okay, it's a secret.
But it's coming.
Yay.
And again, the important thing is just the volume of things. There's so much noise, right? I know it feels like eternity when you're suffering, but there's tons and tons of things coming. It's really important.
Awesome to know. So this actually sounds like me too, Natalie. I tried all CGRP medications. None of them worked. Are there any new medications coming up from other classes?
Yes, so the PACAP will be coming, the central sensitization medications will be coming. And I think it's always important. And it's the hardest thing, but remember, sometimes we have to fold in our old drugs with our new drugs. So something you may have had a partial response with in the past, at a low dose or a medium dose, maybe you can put together with the CGRP and get more than you got from it before. And a lot of our patients were told they had to do either Botox or a CGRP, and that has been, so for a lot of my post-COVID patients, that's been really, really helpful for them. Now that we can get it paid for, right?
Yeah.
Because otherwise it becomes prohibitive.
Doing them together. Exactly. Right.
Yeah.
And again, everybody advocate for yourself, keep fighting. So if insurance says no, I always say, again, this is in our support groups. I always say, ask your doctor for help. Ask them if they can write you a note, tell them why you need this medication or this, whatever it is. And I'm sure Dr. Diamond, you do that all the time, right? Help your patient to try to get the next medication.
Right,
So
absolutely.
just keep fighting.
We have to keep
And so
fighting.
many,
Right.
ahead.
And we get to advocate, and it's hard. I feel like I'm very blessed because I have a lot of support staff. I mean, a lot of single practitioners don't have the gifts that I have in terms of people helping.
right.
Yeah, so it's hard.
Even you could write the letter and have the doctor sign it,
Absolutely,
something like that.
absolutely.
Yeah. So keep advocating. Okay, let's see what else we have here. So after trying a number of meds and therapies over years, why doesn't my immune system heal the migraine eventually on its own?
Well, because it's a different system. It's think of migraine as for most people, a genetic part of your, it's part of your DNA, right? And so right now we can't necessarily modify that. Well, it's a disease. It's not like a bacterial infection. However, there are people working on a vaccine. So maybe one day,
We hope.
we
Fingers
hope.
crossed.
Fingers crossed.
Yeah. Thank you for the information. Glasses that do not have prescriptions most are returnable. Obviously, if you put a prescription in it, they are not returnable. So thank you
Right.
for that information. Let me see what else we have. We answered the development treatments. Here is one. There's no name. I was born with being an albino and I still get chronic migraines daily. I take propranolol, Nurtec, Ajovy. I don't find it helpful. I've taken rizatriptan and amitriptyline. I've experienced Ajovy that messes with my IBS. Is there an injection that covered under state insurance that would be covered that could help?
Yeah, that's a lot. I mean, I actually have a patient in that situation.
If that helps, I'm here.
Hi.
Oh, yeah, there you go.
Yeah, I mean, I think, and do they feel like your visual stimuli is a big piece of it?
So what happens when I take my Ajovi is it messes with my IBS and constipation. So
Uh-huh.
is there a injection that would help not face that issue?
Yeah, so I have a patient in your situation who actually has a medical card. She's a disabled school teacher. And she's been able to get Vyepti or Eptinezumab for her chronic migraine, which is the intravenous one. And she's able to get it covered. She has tried the other ones, and I think that's how we got it covered for her. And she has not had a lot of GI symptoms with it. I can't say nobody does, but it's probably the cleanest in some ways of most of the ones we've used. I mean, I think relatively they're all much cleaner than our old medicines, but they're only clean if you don't have a side effect with it, right? It's only as
Yeah,
good as
that's true.
for you, right? So,
Very true. Yeah.
Yeah.
Is there any way to send me the direct message of that information?
yeah,
I'm
sure.
not sure how.
Well, you
That's
can,
what I was asking.
yeah, no, that's okay. I can give Kelly my email and then you can send it to me. How's that? Is that
Okay,
okay, Kelly?
that works.
Katie, yeah,
Thank you.
you can,
Oh, Katie, sorry, I'm sorry.
that's okay, no problem.
I was
Okay,
up with,
yeah.
I was
And,
up with my mom last
if
night. I
you,
apologize.
yeah, if you email me, then I can get your email as well. Okay.
Sounds perfect.
We have posted the questionnaire in the link. So if you guys want to fill that out, we do have 2 questions that were actually emailed to us. I want to ask those real quick. If you can answer those while you are filling out the survey. What happens when all of your symptoms come back full force after not having them for a while?
Well, here's what I would say. So the reality is today we have treatments, we don't have cures, right?
Yes.
I've had lots of patients go into remission. That can happen. It's great. And sometimes something will set off a trigger and get you going again. I think if you are someone who's sat in chronic migraine, or you're somebody who sits in that place where you have more than 8 to 10 migraines per month and you get really good control, the most important thing for you to do is if you get a headache back that's bad, you got to jump on it because your brain can relearn headache. I mean, that's my experience, right?
Yes.
So it's always important. Like I sometimes see, I saw a lady today, I see her once a year. She's, like whatever monoclonal she's on has been magical for her. But we always refill it, right? Sometimes she'll kind of take it out 6 or 8 weeks because she's doing good and maybe get a little something. So she goes back. But she knows to call me if she ever gets in a cycle because she just gets totally disabled in a very short period of time. So,
Wonderful.
right now we can treat, we can certainly put people in remission for periods of time, but I think this is something they say in AA, but your disease is still sitting back there waiting for you if you let it in. So
Yeah.
always remember the tools. I think that's super important.
Wonderful. So, right. Yeah, you're right. It's kind of like AA. If we're going to go out and drink 3 glasses of red wine, we're asking for it, right?
Right. Yeah.
That's wonderful. So who wouldn't love to have Dr. Diamond as their headache specialist? I'm telling you, you were fantastic. We thank you. And as you said, you had someone from South Carolina, you're in Chicago. That's why so many people do travel to you as well, because you're so wonderful. We thank you so much for this evening. I want to thank our sponsors again. If I think I've gotten to all of our questions. Oh, there's one more here. Let me ask one more question. What CGRP inhibitor has the least side effects? Do you have a,
Yeah, not to be flip, but the one that has the least side effects for you. I would tell you that I think Vyepti, if you look at the data, probably is the cleanest of the group. It's also the hardest to get approved. It's also, you know, if you don't have good IV access and you're a migraine nurse, so you might not, sometimes that can be a challenge for patients. I think my experience has been probably a Jovi of the sub-Q. But again, it's the one that you tolerate the best. You know, God made us all different, right? So I have a family that I treat where I treat the mom and their twin girls. They're all in their 40s and she's in her 70s now, but you know, and another sister, and they all have migraine and they all took different triptans. And they would all come together and meet in Chicago. They were from like the western suburbs, and they would all meet and go out to lunch after their appointments. And they would argue about which triptan was better. And I'm like, it's just the one that works for you. It's
yeah,
okay.
you're all blood, but you're all different, right?
Right.
Oh, that's a cute story.
It's true.
Well, we thank you, and everyone on here says you're amazing. Thank you. Dr. Diamond's the only doctor that helped me. So you have some patients on here. We thank you very much.
Thank you.
And everybody, thank you for joining us this evening. And we hope to see you next year on our other education days. We're in the process of lining them up for next year.
Anytime.
We have our Miami, if anyone on here is from Miami